Medicine at the University of Chicago and also the Associate Director for the Head and Neck Program. And he'll be talking about approaching head and neck as an immune-sensitive tumor. Welcome, Tanguy.
Yeah, I wanted to thank Ravi, Suresh, and Everett for inviting me to the tropics in winter. Chicago is turning really cold, and I think it's kind of really nice to be here. It's beautiful. And I have one suggestion for next year's meeting. Maybe we should actually move the meeting a little bit further to the beach. So if you don't care about small cell, you could just take a swim in between. And I thought that would be a good suggestion. I don't know about the logistics, but maybe for next year. So I'll be talking about immunotherapy and head and neck cancer, and I think Everett already introduced this topic briefly. I wanted to, first of all, figure out the pointer. Down, oh, I was going up, So as many of you know, there's this concept of injecting bacteria into tumors. This was Cooley's toxin 126 years ago, done at Sloan Kettering. This actually was a head and neck cancer, as you can see here, and this tumor responded. And this minor newspaper called the New York Times, said that 150 sure cures. I think I've been doing something wrong actually, but really I think there's a precedence for immunotherapy in head and neck cancer that dates many, many years back, decades back. And this is my own contribution to this very same concept. I cannot prove that this is really fully Cooley's toxin. This is a patient who was enrolled day one, starting pembrolizumab PD-1 treatment, had a number of skin metastasis. In fact, this is already a few days in. And then the second day developed a rather extensive cellulitis with MRSA. And usually when you look at these swimmer plots, responses occur at 8, 12, 16, sometimes 20 weeks. This was a near complete response within 2 weeks. I've never seen anything like it. And I really wonder if maybe the bacteria kind of revved up the immune system further, and maybe that's my contribution to Cooley's toxin. But I think, again, it shows you that this is a complex system, and we're just scratching the surface of immunotherapy at this point. So, my little conclusion to this slide is maybe we shouldn't be doing all these things. Maybe we should actually not do what we've been taught in medical school, Finally, this is a timeline of immunotherapy. In the interest of time, I won't go through the discovery of T cells and BCG, et cetera, but you can see here that there is a long history. And Science actually in 2013 said that cancer immunotherapy is a breakthrough of the year. Quite frankly, I think science is wrong. I think this is a breakthrough of the decade, if not of the century. There will be at least one Nobel Prize for this, and you can see on which side I stand on this. I think this is a really major breakthrough that's going to go across many, many tumor types. So with that, I wanted to briefly talk about the phenotype we're talking about specifically in head and neck cancer. This mirrors some other diseases such as squamous lung cancer or other virally associated tumors. I want to show you very briefly some clinical data, and in particular show you a first look at survival data in head and neck cancer. I will briefly talk about biomarkers as third, and then talk about the future, and I'll try to do this quickly. So these were actually data presented by one of my colleagues in 2014, looking at the phenotype of head and neck tumors. When we first started looking at gene expression, we tried to identify, just like Chuck Peru in breast cancer and Neil Hayes in lung and head and neck cancers, we tried to identify intrinsic subtypes of cancers, and those are actually shown here. This is an EGFR hypoxic subtype, cell cycle, and then there's this phenotype, which is inflamed mesenchymal, we call it. It has extensive infiltration, or it has extensive biomarkers, CD8, ICOS, a T-cell activation marker, checkpoints here. And when I showed this to Tom Gajewski, and at the time I didn't have much appreciation for immunotherapy, he said, "This looks like melanoma. You should run with this. You should actually make something out of this." And sure enough, when we worked further on this, some of these markers you can actually see. There's this whole measure of immune escape markers compared to this balance with immune surveillance. And when you look at this by gene expression, you can see that a number of checkpoints are active in these inflamed tumors, T-cell inflamed tumors, including both an HPV positive and an HPV negative subtype. And so we all talk about PD-L1, but really what we're talking about in my mind are inflamed tumors and non-inflamed tumors. And I'll try to convince you towards the end a little bit more that the substrate of immunotherapy is inflammation. I think if we can really make this entire pool of patients respond to immunotherapy, this would be a major step forward. turning the non-inflamed tumors into inflamed tumors, I think, is a much larger challenge. And I always believe you go for the low-hanging fruit first and then you work your way up. But you can see here, for example, another discovery that FOXP3, a marker of T regulatory cells, is highly expressed in HPV-positive tumors, but not so much in the HPV-negatives, while macrophages are much more common in the HPV-negative. And I think while PD-1 seems to be active across both entities, when we think about the future, about combination strategies, I think likely we will need some sort of profiling, immune profiling of tumors as well, and the cocktail of immunotherapy may eventually depend not just on inflammation, but more on the finer points of what type of inflammation is present. So, you can say, well, this is all nice and good, this is gene expression, but what we really care about is, protein and looking at actual tumors. And this is an immunofluorescent picture where on the left you see an inflamed tumor, green are CD8 positive cells, red is cytokeratin staining. This is an HPV positive tumor that's highly infiltrated with CD8 cells, and this is a non-inflamed tumor. And as it happens to be, PD-L1 just comes along for the ride, is also there. And when we looked at this, this is actually using the Genentech assay, using samples from the University of Chicago. You can see these various patterns that you probably have seen already: a completely negative tumor, a tumor that only stains in the immune cells. So sometimes you have this pattern that only macrophages or other immune cells stain within the tumor stroma. Then you have patterns where the tumor stains for PD-L1, and then you have tumors where both stain. And we actually don't understand what that fully means. It is clear that all of these can be meaningful, and when you look at the companion diagnostics, the assays, many of those now look at both immune cells and tumor cells. So when you look at this for head and neck cancer, using a stringent cutoff, there's at least 40% of tumors that have extensive PD-L1 expression, so the equivalent of 2+, 3+. But if you set a lower cutoff, it goes as high as 70%. So, looking further, trying to understand the molecular basis of what inflammation and non-inflammation does, there's some pioneering work again from Tanguy Seiwert. We just try to associate, genetic phenotypes, pathways. But the one thing that I think was very clear, and this is not simple, but the one thing that was very clear is that Wnt signaling or beta-catenin in head and neck tumors does seem to be quite important in suppressing inflammation. And this was a paper that came out in Nature by Tanguy Seiwert, looking overall in melanoma, and I can tell you this is also true for head and neck cancer. So that's the basis. We have an inflamed tumor that's present in both HPV positive and HPV negative, but does it actually mean something? And so I wanted to show you some clinical data. These are data from this year's ASCO using the anti-PD-1 antibody pembrolizumab. You may already have seen this. This was a 130 patient cohort, regardless of HPV status or PD-L1, so an unselected patient population. These were heavily pretreated patients, typically a phase 1 type population that is not a good prognosis population and has this newer treatment schedule of 200 milligrams every 3 weeks. This is a waterfall plot. You can see here that the inflection point is at about 56%. So 56% of patients show tumor shrinkage. And I specifically decided not to show you the response data. The response data is 25%, so 1 in 4 patients response, including both HPV positive and HPV negative patients. But the problem with response is that it clearly underestimates the group of patients that actually have benefit. And if you look at lung data, for example, Checkmate 17, you see a shift of the median survival, not because you have 20% of patients who respond, but you have an additional 20, 30 or more % of patients who actually have some benefit when it comes to survival. And I do believe that this subtype, this subgroup of patients is also important. And while these patients respond, this is really, I think, the next step where we have to work on. Clearly, these are immune-amenable tumors. And just to show you one picture that I think says it all, why this treatment is so effective and so impressive. So this is a patient actually treated in Seattle with a rather extensive tumor, was given a single dose of pembrolizumab, developed tumor bleeding, enrolled in hospice. And as it turns out, this was not sign of the tumor progressing, but it was actually a response. Within a few weeks, the tumor started to shrink. The patient had a complete response. The patient was unenrolled from hospice and re-enrolled on the trial. And this is not the type of treatment effect we would see in an advanced tumor with any other treatment. And so I think this says a lot. And this is not just true for head and neck tumors, but I think it's true for many subtypes, many tumor types. And I count at least 12 tumor types where it looks like we will probably have enough data or enough activity for approval. And ultimately, it might not be by tumor type, but it might really be identifying the right subgroup of patients. You show this beautiful data with MSI in colorectal tumors, and I believe that subtype of immune-amenable tumors will be present in many, many cancer types. And so this is maybe the most important, or one of the most important slides. So we try to use our patient group of about 190 patients, combining all data we have with pembrolizumab and head and neck tumors, and draw a survival curve. And you can see this flattening out of the curve, looking at overall survival. Median overall survival is close to 10 months. And that's pretty darn good for a population that is second, third line treatment, where it's usually 4, 5, 6 months of median overall survival. And just to put this into perspective, I think you saw the slide already, this is the very best treatment we have for recurrent metastatic disease. This is the extreme regimen, doublet chemotherapy, platinum, 5-FU, and cetuximab. You can see here the curve with cetuximab and the curve without cetuximab, the extreme regimen shown by Jan van Morken in the New England Journal of Medicine. This is first-line treatment. And so I took the liberty, and again, this might be a bit flawed comparing between trials, but I'm comparing arguably a much worse patient population with this, and so I overlaid the pembrolizumab curve, the PD-1 curve with that, and it looks at least as good as doublet chemotherapy, and ultimately it might actually look better. So this is an unselected patient population, heavily pretreated, that looks as good as first-line treatment. Again, take this with a grain of salt, but again, looking at lung cancer data, where you saw a really impressive treatment effect in the squamous cell population, I suspect we might see something very similar for head and neck tumors. So there's also data with PD-L1. This is durvalumab, the PD-L1 antibody from AstraZeneca. It also shows activity. I think this is a somewhat worse patient population, and the response is somewhat lower, although I really don't know if this actually means something. Again, I think responses are problematic. We have to look at survival, but clearly there's activity also with PD-L1 agents. So I think we will see more data, and many trials are ongoing. So finally, I wanted to talk briefly about biomarkers as they apply to head and neck cancer. You've already heard quite a bit about PD-L1 staining. This does work for head and neck tumors as well. There's a bimodal staining pattern. Some tumors have low expression, some tumors have high expression. And so when you look at where a different company sets their cutoff, many companies will set it right here so that you only have the high expressions, but sometimes the cutoff is set here. So you have to be very careful where the cutoff is and also how the assay is done. But we can enrich for higher responses in head and neck cancer. And again, I think PD-L1 is a flawed biomarker that allows us to enrich for higher response rates, but ultimately we cannot exclude patients from treatment, given that patients, even who don't have high levels of PD-L1 expression, do at least as good as, for example, cetuximab, and have sometimes lasting benefit. I wanted to point out that there is actually now an assay for PD-L2 staining, and here's an example of a head and neck tumor expressing PD-L2 in tumor cells, and sometimes it doesn't express PD-L1. We actually don't know if PD-L2 is clinically meaningful. There was some pilot data from Merck, so keep that in mind that this is maybe biased data, but at the same time, it did suggest that PD-L2 staining may be important and may also be a biomarker, and we look forward to additional data. The other thing I wanted to point out is that there is now also an immune signature, and people say, well, signatures are nice and good, but they're so difficult to implement, and gene arrays are problematic. Well, I would argue that this is arguably an assay that will have potential as a clear assay in the very, very short near term. So this was done using the NanoString platform, which is compatible with FFPE tissue and can handle very low amounts of input material and is reliable and robust and easy to reproduce. And this is being developed as an assay looking at immune genes. There's a 6-gene interferon gamma signature. And this is arguably, in my mind, the other really important slide. And so I like to classify tumors, and this is true not just for head and neck, but also for melanoma, gastric, bladder. This assay works in many cancer types into 3 categories. There are the inflamed tumors that respond, and they actually all clustered in this red box here. So these are high in interferon gamma, and they respond to PD-1. And so clearly we're doing something good there. But then there are also inflamed tumors. These are the green box that are non-responders. There is inflammation there, but PD-1 alone doesn't seem to be good enough. And so, in a sense, what does it take to shift these tumors up from here to here? Does it take CTLA-4? Does it take a second checkpoint? Does it take bacteria? What does it take? But clearly there's a substrate already. And that, in my mind, is a low-hanging fruit where I think the next progress will happen. And then ultimately we have this blue group of non-inflamed tumors, which I think are arguably the hardest tumors to treat. Maybe beta-catenin, as I showed you, will play a role, but this is a third group of tumors. So with that, I would actually like to conclude. The future, I think, is quite bright for immunotherapy in head and neck tumors. There's a number of phase 3 studies ongoing. In fact, nivolumab is fully enrolled. The phase 2 study by pembrolizumab is fully enrolled. There are phase 3 studies in the first-line setting, both using durvalumab plus tremelimumab, CTLA-4, as well as pembrolizumab. And I think there's really a lot of data forthcoming. We really have two approaches, taking off the brakes, using checkpoints, or stepping on the gas, and all of these approaches are being explored right now, and I think a lot of trials are going to come to head and neck cancer as well. And just to show you a few of the examples that are ongoing, this is being studied right now already in head and neck tumors, combinations with CTLA-4, including tremelimumab, or intratumoral ipilimumab is being explored now. There's a combination with durvalumab, there's adjuvant PD-1, there's combination with IDO, really a lot of interesting data forthcoming. So with that, I would like to conclude that head and neck cancer is clearly immune amenable. There is extensive infiltration in a subgroup of about 40% of head and neck tumors. Immunotherapy using PD-1 agents and PD-L1 agents is clearly active, and I would argue very active in both HPV positive and HPV negative tumors. The response rate in an unselected population is twice as good as cetuximab, but many more patients seem to benefit. And again, I think we need to look at survival, not a response. For biomarkers, PD-L1 is problematic, but it does enrich, but there are new biomarkers that are forthcoming, and there's multiple phase 2-3 studies that are ongoing. If you slept through the entire talk thinking of the beach tomorrow, this is a quick summary for everybody. So this is how the cancer usually is. Nobody recognizes it. They think it's a friend. And what immunotherapy just does, it makes it visible to the immune system, and they start attacking with this little gun. And so that's a summary of immunotherapy in one slide. I would like to thank the many mentors that have contributed. I come out of Ravi's lab, and I'm eternally thankful for all that he has done for me. And it's very sad to see him leave for California. I hope it was not just the weather. But I want to also thank Everett and the terrific head and neck cancer group we have in Chicago. My collaborators, at Stanford, Holbrook, at Merck, Genentech, Jounce, and many, many others. Thank you so much for your attention.
Tanguy, thank you. Quick question is, any role for the microbiome besides the Coli toxin?
I think the answer is probably yes. There was just a paper about lactobacillus, again from Tom Majewski's group, suggesting that changing the microbiome in the gut may lead, at least in rats, to much more sensitivity. So I think there's an interesting signal. So the gut bacteria play a role. Cool's toxin works. In head and neck cancer, we care about the oral microbiome. There clearly is an interplay between bacteria and tumors, but I'm not sure that we fully understand it. But when a patient asks me, should I take some lactobacillus, I always say, I don't know, but why don't you do it? It's safe. So I'm not sure. I think it's a clear opportunity. And I've been trying to convince our surgeons to inject MRSA into tumors. I'm still looking for somebody to do this, but anyway, if there are volunteers, please let me know.
So that was a great talk. My question relates to the data with the interferon gamma signature. These are from baseline tissues.
That's right.
Before the patients were exposed.
That's correct.
In theory, what you would expect is when you rescue the T cells with the checkpoint inhibition, that's when you would see the interferon gamma and other granzyme and other things go up. So how does this mechanistically fit into a potential predictive biomarker scenario?
So I think you're correct. If you look at Roy Herbst's paper with atezolizumab, it does seem, and we know this also from many other reports, when you have successful checkpoint blockade, when you have a successful breaking of immune tolerance in the tumor, there's a rush of additional immune cells, mostly CD8 cells, into the tumor. And then you see much more interferon gamma, and you see much more expression of PD-L1. Interferon gamma and PD-L1, they're almost the same. They're directly related. Interferon gamma induces PD-L1. So I do believe that if you have a baseline interferon gamma signal, that's a very good biomarker that you'll see more if you enhance it. I don't know where to set the cutoff. And I think there's probably a lot more. There's many ways of doing immunosuppression. So I think it would be lovely to have dynamic biomarkers. I think if we had an imaging tracer for CD8 or for PD-L1 that would light up after 1 week or 10 days, I think that would be terrific. The other thing that came out in the previous discussion or question was, can we do a blood-based assay? And so blood-based assays are good for mutations. They're a bit more difficult for PD-L1, but there is an effort, again, looking at a gene expression signature that might actually be a dynamic marker, and that you can obviously do multiple times. So I think it's promising, but I don't know the perfect answer.
In lung cancer, we are starting to see more and more a kind of a relationship between driver mutations and immune activation, represented by PD-L1 expression. Do you know, is there anything in head and neck in this direction or something indications here?
We have looked. Obviously, unfortunately, in head and neck cancer, we don't have the simple drivers that we can target with one drug, and I'm eternally envious for that with respect to lung cancer or lung adenocarcinomas. So with the squamous tumors, both with the HPV positive and the HPV negative, which are really two different biologies, we have correlated in TCGA in our own genomic data set inflammation and genetic changes, mutations, copy number. The one thing that does come out is that EGFR amplification and expression is anti-correlated with an immune phenotype. So it seems like there's some level of immunosuppression. And then there's also a signal with histone methyltransferases that goes the other way. The only thing that was positively associated was JAK2. But JAK2 is actually genetically right next to PD-L1 CD274, and so it might just be a co-amplification. Bob Ferris has done some really nice work there. So the simple answer is I'm not sure it is as simple in head and neck cancer, and unfortunately we might have to look at lung adenocarcinoma again. Yeah.
It's not simple in lung either. So.
Well, life is complicated.